Afternoon, everyone. Good afternoon. Thanks for coming, those in person and also those are online. The Innovation Translation Council, ITC, is part of the research at BSPH ecosystem. Our purpose is straightforward. We help investigators turn their research into product and scalable solution that can move the needle in public health. We see translation not as a bonus, but as an essential pathway to fulfill our school mission to improve health millions at a time. If you're new to this space, we hope you will see it as a new lever of delivering public health impact. As part of the efforts to educate our community, because we want to learn about this more and more, we're expanding our 360 series at BSPH with a new track, Innovate360. This series is designed to give our faculty, staff, and also students a clear view of how ideas become real-world impact. From identify unmet needs to product development to market analysis to practical realities of scaling. Innovation translation is not a mystery. It is a process, and we intend to make this process visible end to end. One thing ITC want to emphasize is that we are not doing this alone. We team up with partners across the Hopkins ecosystem who bring deep expertise in engineering, business, and commercialization. One of those partners is the Center for Bioengineering Innovation and Design. Their leadership, particularly Dr. Youseph Yazdi, has been instrumental in helping our faculty and students think not only about prototypes, but about market scaling solutions and ultimately how to deliver innovation that actually reach the public. Before introducing today's speaker, brief plug for our next Innovate 360 section on January 8th. We'll not only focus on tangible products, digital solutions are central to modern public health translation. On January 8th, Rose Wang, recently featured at Johns Hopkins Innovation Summit, will come to speak to us about her journey creating a digital platform that bridges patients and clinicians after seeing firsthand how difficult it was for her late husband to find clinical trial during cancer treatment. It is a very powerful example of identifying a gap in our health system and building something that matters. So please register and join us. For ITC, we're here to help our community to team up, show up in the right community, and scale up together. Together, we have the privilege of hosting Dr. Youseph Yazdi. Dr. Yazdi is Associate Professor of Biomedical Engineering, Executive Director of the Center for Bioengineering Innovation and Design, and Program Director of the Wallace H. Carter Translation Research Partnership Program. He holds degrees from Rice University, the University of Texas at Austin, as well as an MBA from Wharton at Penn. Before joining Hopkins, he serves as a corporate director at Johnson & Johnson's Office of Science and Technology, leading partnership that support early stage health innovation, which is exactly that's what we need in our School of Public Health at this stage. He is a fellow of American Institute for Medical and Biological Engineering, an advisor to several academic organizations, and inventor with patents in ultrasound and biophotonics technology. In the early conversation with Youseph, one thing stood out. He told me to truly serve the public, we must know the market. Today, we'll discuss how engineering public health collaboration strengthens proposal, creates scalable innovation, and accelerates impact from bedside to community. He will also highlight the master program, which follow a true bedside to bench to bedside model, identify unmet needs, developing solutions, and bringing them to market. So please join me to welcome Dr. Youseph Yazdi.
Thank you so much, Professor Lung. Thank you for School of Public Health for organizing this amazing initiative. And I hope this is the start of something big in terms of our collaboration. Our center has been focused since our founding in 2009, mainly on our collaboration with the School of Medicine. But I think the time is now where we want to step up our impact and have the kind of impact that you all have in the School of Public Health on a global scale. My name is Youseph Yazdi. My degrees are mainly in engineering and some in business. I spent most of my career in industry at Johnson & Johnson, as Professor Long pointed out. The logos on the screen kind of tell you about our organizational affiliation. We're part of the School of Medicine and the School of Engineering, and part of the Biomedical Engineering Department, which happens to be the #1 ranked biomedical engineering program in the nation. I usually start my talk with this photo. I really like it because it says a lot about who we are and how we do what we do. This is one of our design teams in a maternity clinic on the mountain in Nepal. And the woman seated there on the left is one of the midwives who runs this clinic. And the 4 students, what I love about the photo is that they're all listening intently. What Professor Lung pointed out is all about problem solving. We're here to solve problems for society, not just to pad our resumes and our CVs and advance our academic careers, or even just to advance the frontiers of science and technology. Our purpose should be to solve real societal problems. And in order to do so, you really have to understand those problems first. So the photo really captures that a moment when our students are listening intently. They all have notepads and pens. They're taking notes carefully. Another thing I like about the photo is that these are 4 students with 4 different passports from 4 countries with 4 different backgrounds. And this is essential to good problem solving, is you have a diversity of opinions in the room. If it's just you and your peers and you all speak the same exact language, you're not going to come up with something new and different. Another thing that's very important about the photo is that to be a problem solver, you have to go to where the problem exists and see it firsthand. Because there's so many things that you understand when you go there and you breathe that air, you walk in those halls. For example, behind the students is a poster. It's a tool that the clinic is using to manage different cases. What are some of the ways, the innovations that people on the ground in Nepal, in Africa, in the clinics we go to are using? And this is so critical. Because the innovation that you do, the level of innovation that you do for a wealthy healthcare system like Hopkins is here. But the level of creativity and innovation required to deliver care at a low cost in an effective manner in a clinic like this is much higher. And we don't have the corner on that market of creativity and innovation. The people in the trenches do. That's why collaboration with people in the country are so important. So our mission of our center, this is something we wrote 17 years ago when we first started our program, was twofold: education and innovation. We aim to educate a new generation of young people to be leaders in healthcare innovation, and we also aim to come up with ideas that have an impact. And this is how we hold ourselves accountable: the impact that our students and our ideas are having on the world. So even students who graduate 10 years in the past will come back to my office and say, can you help me find it, my next thing? Because I measure my success on their impact on healthcare in the world. We have a great team, an awesome team. I think Professor Acharya, who is a co-founder of the center, he gave a talk here a few weeks ago. His entire innovation academic career is focused on global health innovation. We have medical directors. We have graduates from this program, as Marina is a graduate of this program recently, and she's the director for our global health programs, projects, and many faculty and staff, people to help students build things, to help them with organizing things. And we also have a large number of fellows, people who finish the program, stay on for 1, 2, sometimes 3 years to get their project up to speed. And this is another important part of innovation, is that you have to have a runway for the best ideas to actually pick up some speed to attract the investment needed to get something done. And we also have facilities for them to build things, try out ideas. This is very important. This was done this is a photo during one of our hackathons, and we'll talk more about it during the Q&A. But before we officially opened the space, we got a grant from USAID, about $700K, to do a big hackathon during the Ebola crisis. And we had about 150 people here in the design studio building things, drawing ideas for improvements on PPE, et cetera. We have a wonderful clinical advisory board, and very important for innovation, an external advisory board. These are people who invest in medical devices early on. These are the investors, the people who are funding things, and we ask them to be on our board. We don't really need their advice. I hope, hope they don't see the recording, but really what we need is there's an expression my dad told me when I went to ask him for money to buy a car. He said, son, if you want money, ask for advice. Because if you ask me for money, I'll give you advice and no money. But if you ask me for advice, I may give you some money too. So we ask them for advice and ask them and get money. So we worked with all the leading med tech corporations. So we have a good model that we've developed over years. And this is one of the reasons why I was brought in to head the center from industry, is because in order to work closely with a partner, you have to speak their language. There's a saying in our culture that in order to be protected from the evils of a nation, you have to know the language of that nation. So corporations are not evil, but they're great. I've learned to. That the subtitle of that movie, Dr. Strangelove, How I Learned to Stop Worrying and Love the Bomb. So my family is very liberal, and I was the first one to go work in a large, evil multinational corporation. But I learned over many years to respect and like that there is some good things that they do. They have some very high standards and very rigorous in a lot of ways. So we love working with those medtech corporations, big and small. We have our own spinouts now that come back and sponsor projects like IntelliHealth and VectorCam. These are spinouts from CBID that are now coming back and sponsoring projects. We work with all the major corporate, funders for global health innovation, and also our work it requires input from payers in the federal government and FDA and regulators, et cetera. So those are also key partners. So I'll stop there for a moment and say, okay, next I'm going to say a few words about our design thinking. How do we approach the idea of design? Okay, how are we doing on time? 13 minutes, okay. So to design something, people have different definitions for design. There's schools of design and design programs, et cetera. So in our definition, to design something is to create a good solution to a problem. So for example, this is a product, you may have one at home. It's a lemon fruit juicer. It looks really nice. But as a fruit juicer, it's a disaster. If you have one, they're like $50 at Williams-Sonoma. They're like really useless. Unless maybe it's good for like if you have a home invasion, you want to hit someone over the head or something. But other than that, it's a disaster. But it looks really nice. So bad design can look really good. Bad design can be bad in so many ways. It could be not functional. It doesn't do the job it's supposed to do. Or it's not effective. It doesn't do it very well. Or it does that, but it's not safe. It introduces new risks. Or it does all those three above, but it's not really usable by the average person, by the person you're trying to get to use it. It requires a tremendous amount of training and expertise to use your product. These are all ways that design fails. Or it does all the things above, but it's just too expensive. Or it's not buildable at scale. It's not scalable. Or it generates so much waste and other harm to the environment that it's not sustainable. The bottom line is, or it could be it's just not better than what's already out there, significantly better. How many projects have you worked on where someone says, our project is amazing, it does this and this and this? Rarely does someone say, and this is why our project is better than all the others significantly, will have significantly better outcomes. The bottom line is it's not valuable to people, to human beings, to other people, and most importantly, from an ethical, moral perspective, it's not a good use of your time. That's our number one ethical and moral imperative in life, is to use our time, our creativity, our resources, the wonderful education you're getting here in the best possible way to have the maximum outcome. Why not work on something that actually has a big impact on the world? So here's some examples, funny examples of bad design. This one I love on the one with the security gate is pretty interesting, design. it solves one problem and creates another problem. Here's one that I love. This is back in the roaring 20s when electricity was starting to be rolled out in New York City, and people, the fire department installed these fire alarms in big buildings. And it was great. You'd pull the alarm, the police it would send off the alarm in the fire station, and the cops would show up. The police department would show up. So young people your age would, get a couple of beers and chairs and sit out in front of the building and pull the alarm and watch the trucks pull up. It was great fun, entertainment, I guess, pre-Netflix. So the chief of police said, "I'll solve that problem. I'll put this locking collar right under the thing. So in order to pull the alarm, you have to put your hand through this thing, pull the alarm, and it locks your wrist there. And you're not going anywhere. So that when the chief of police comes with the key, he'll see if there's a fire, if there's no fire, he'll fine you for the false alarm. If there is a fire, I guess he'll come and unlock your burned out skeleton, and anyway. So it solves one problem very effectively, but it creates another problem. How many times have you seen, this is a funny example, but how many times have you seen this in public health problem solving, in medical problem solving? Happens all the time. Medicine is rife with poor design that kills people. This is an EpiPen. My daughter uses it. She's an entomologist, but she's allergic to insects, bees. So she carries one of these around. Every year, 30, 40,000 Americans accidentally pick up their EpiPen and stab themselves in the thumb. And you say, because they're idiots. But it's not. It's a bad design. When your eyes are swollen and you're panicking and you want to give yourself a shot, why is this pen designed in a way that you can't tell the orientation by touch? That's a poor design. So sometimes we think they're very effective, but until you try it out in the field and people are using it, you don't really know if you've done a good job or not. Good design can be amazing. This is a product I worked on when I first started at J&J. It's an incredible product. It allows a surgeon to take your gallbladder out through a tiny opening. It cuts, coagulates, staples, in one shot, grabs the tissue and pulls it out. And it also looks nice too, if I dare say so myself. It's nice looking product. Doesn't have to be ugly just to be good, but it does the job. And it's cost effective. Here's some examples of CBIT projects. I won't go into all of them, but good design can be good in so many ways. It could improve healthcare outcomes. Of course, that's what everyone focuses on. But it could lower pain. It could take something that requires a lot of manual steps and automate it. It could be an innovation that takes something that requires a high level of skill and make it so that a person at a low level skill can do it. For example, we're working on a project right now that takes ultrasound, which requires a high level of training for breast cancer screening, and using AI makes it so that a person with low level of screening can pick up the transducer and do the scan and have equal performance in diagnosis. Or it lowers cost, improves training, lowers risk, reduces waste, increases access to care, empowers people to take control of their own care. There's a product we worked on and focused on Uganda to allow newborn parents to know whether baby is at risk for sepsis. What are the signs for sepsis? So some of them are things they have to observe and some things that have to be measured, like heart rate and temperature and that sort of thing. So we made a very simple tool that they could get when the baby is born. They get this tool, they put it on their baby, and it gives them some warning signs your baby may have sepsis. Call the local community health worker to come and take a look, etc. But good design is really a journey that starts with empathy and passion. Here's some photos some of our students have taken. This is an OR suite, believe it or not. We saw in the Sundarbans on an island in the Sundarbans, the India part of the Sundarbans, in the Bay of Bengal. We met some people who had C-sections done there. And you have to go and see it for yourself. And then you develop an intuition and develop a passion. People say, where does creativity come from? It comes really from passion. When you're so engaged in the problem that you wake up in the middle of the night and think of a solution. You don't have to constantly be nudged. You're driven to solve it. And that should lead you to care and clear and respectful understanding. So these are two of the main principles we teach in our program: empathy and going to the place where the problem exists. But in medtech innovation, there a death by 1,000 cuts. There's 1,000 ways that an innovation project can fail. Here's my list, of 50 of them. But how can anyone deal with all these issues? The problem is that we all gravitate to our own expertise, and it's really hard to take this comprehensive approach. So the first thing we do, given being we're academics, is simplify by categorizing things. So we take all these issues and put them into 4 thematic buckets. All the healthcare related issues, the doctors, the nurses, the other care providers, the patient, their family, Ministry of Health, a very big player in this in global health, care pathways, the evidence that the solution has health benefits and is safe, and will be integrated into care, and the clinical risks. That's one bucket, okay? The second bucket is all the things that have to do with business. That has to do with what is the value proposition? How much, let's say you're going to the Ministry of Health and saying, buy my thing, buy my program, or buy my device, my innovation. We're going to say, okay, tell me financially, how is that a good deal? How much money will I save if your project works? And how much is it going to cost me? Is there a positive value proposition there? The same thing that CMS does, the same thing the insurance companies do, the same thing the Value Analysis Committee does here at the hospital. Tell me why paying $1,000 for your product is going to save me $1,500. So what is that value proposition? How do you capture and protect that value? Who's going to pay for it? Who's going to regulate it? Who are your competition out there? And all the business risks associated with the project. The third bucket is all the stuff that the nerdy engineers like me, like to focus on all the time. And that is just the engineering, the technology, building things, prototyping things, trying it out, all the technical risks. We're really comfortable with that. But the fourth quadrant is actually the most important one. That has to do with execution on the project, the entrepreneurship quadrant. And that has to do with all the organizational and strategic and operational issues. The reason why we've categorized all these and made them very explicit is very important. Because if you look at the failure modes for innovation projects, the failure modes can emerge from any of these quadrants. Neglecting any of them is going to cause your project to fail. So think of it as a Cartesian space where you have these 4 quadrants and you have to fill out the whole space. The center of the space is time 0, $0. And as you go out, you're spending more time and more money and more effort, and you're building confidence. So eventually, and you can subdivide these quadrants into subdivisions as well. So eventually you have to fill out the whole thing. For a new medical device in the United States, it typically takes 5 to 10 years and $10 to $50 million. So the question is, where do you start? How do you start? You can't, one approach is just to raise $10 million and start doing all of it all at the same time. That actually can cause you to fail, having too much money, because you'll end up spending so much time and money. And I've done this at J&J. I've spent $1 million. Some doctor said, I need a better gadget. Come back $1 million later, a year later, and say, I built it for you, doctor. And he looks at it, he says, now that I look at it, I really don't need that. I was about to want to stab the guy with this. But, now that I look at it, I say, that's not really what I need. What I really need is a way to solve this particular problem. And that's why I actually and I'm loath to go back to my boss and say, I just wasted a year and I wasted $1 million. That's why having too much money actually can be harmful. And another thing is that these things interact with each other. The medical value proposition impacts the business value proposition, the willingness to pay. That impacts the design. If people are only willing to pay $10 per patient per case, in Africa to treat a certain disease, your solution can't cost $15. It has to cost $5. And then the team and the relationships and the resources you have on the entrepreneurship quadrant affects the kind of projects you can work on and you're able to succeed on. So a linear path fails. Typical graduate program is like this. I did mine at UT Austin in a laser lab, and my advisor said, Youseph, you can work on whatever the hell you want to work on. It better end up using a laser because this is a laser lab. And guess what? I came up with an amazing diagnostic test, replace the pap smear, which has like a 60, 70% specificity and sensitivity. It's not a great test, but because it's a slow-growing cancer, you get the test done over and over again, eventually it'll get caught. My test had 95% sensitivity and specificity. But it required a $200,000 laser with 3 optical fibers, a bunch of technicians. It's never going to help anybody. It did get me a PhD. It did get me papers published, but it never helped anybody because I neglected these other issues. And I assumed that just because technically it works, it's a win. A better process is a linear process where you say, okay, I understand the medical problem. Then I'm at the first yellow dot. I've understood the medical problem. And then I create a solution. And now I'm at the yellow dot. Now I've solved the problem. Then I look at all the business aspects of it. And now I have a business plan and a regulatory plan, reimbursement plan around it. And then I execute on that. How could this go wrong? This makes a lot more sense, right? Anybody want to venture why this could go wrong?
Not linear. Too slow.
What's that?
Too slow.
No, it can go fast if you have enough money. It's a lot of arrogance in this approach. You're assuming you totally understood the problem, and then you've assumed you totally solved it. You know, how often has it been that you don't really understand the problem until you start trying to solve the problem? You start, wrestling with the problem. And in that wrestling of the problem, you have the inspiration of, oh, I missed this aspect of it. I missed that aspect. So that's why this linear process fails as well. And this is commonly done in industry where there's a lot of money and a lot of room to fail, but it's not good if you want to do an efficient, cost-efficient way in an academic setting. A better approach, creative problem solving is more like hiking in the mountains. You can't see the full path forward. You can see maybe 100 steps ahead of you, but you have to take those 100 steps before you can see the next 100 steps. So you have to be biased toward action. There's a quote from E.L. Doctorow. He says, it's like driving at night in the fog. You can only see 10 feet ahead of you, but as far as your headlights can show you, but you can go the whole journey that way. So this is the approach that we teach in our program. We follow this spiral iterative path, and it takes you through each of these quadrants, like Dorothy and her compatriots going through this pathway. And the idea is you do a little bit of work initially on the understanding the medical problem, a little bit of work understanding the business opportunity and the issues there, a little bit of understanding of the solution, maybe do some back of the envelope brainstorming, and then you do a little bit of work putting together the team and the resources you need, and then you stop and you do an assessment and you say, okay, does this make sense from all four of these perspectives? And if it does, you go forward. And if not, you modify your direction or you kill the project. And if it, hopefully if everything looks good, then you go in greater depth in each of these and be willing to change directions. This is very important. This is something academics are very difficult. An academic is very loath to kill a project. Projects I've seen, my colleagues who stayed in academia, we worked on biophotonics for cancer diagnostics, and you ask them, what are you doing? I'm doing biophotonics for cancer diagnostics. And 30 years later, they're still doing the same thing. They're very loath to change direction or to kill projects. And you notice that in each iteration, you're building on what you did before. For example, understanding the opinion of a healthcare worker. You don't have to do a massive survey, like is common in public health, where you go and interview everybody in a certain community or large numbers to get good statistics. You can start with a few experts, get enough confidence that you're on the right track, and then build up the rest of the project, and then go back and get further input, and then get further input. That way you're building up confidence, and you're doing it in a very frugal manner, cost-effective manner. The same thing for regulatory issues. Instead of paying $200,000 to have someone come in and give you a regulatory consult, instead, you have an initial 1 hour conversation, and then you'll do full analysis, and then you'll have as time goes on, and you'll build up and expand your work. Kind of like eating pizza, right? Only a crazy person starts with the crust, right? You always start with the tip and gradually build your way out. So there's a lot of value to this spiral iterative 4-quadrant model. It encourages you to pay attention to all the issues early in the innovation process. It encourages you to define your design inputs and constraints from all. That means that not only technical and medical constraints, but also business constraints, like how much is it going to cost in the hands of the user? And allows you to start with, in each of the quadrants, I didn't go into that, but you don't have to necessarily start with the clinical side. You can start with some other quadrant, but the key is you don't go past that first iteration until you've really assessed it from all 4 perspectives. So the CBIT year in our master's program is 3 phases. Phase 1, 1/4 of the year, 1/3 of the year is identifying a good innovation target. And this is the unsung hero of innovation, is choosing wisely what you're going to actually work on. The second phase is the next 4 months, is actually coming up with a wide range of solutions, not limited by Dr. Yazdi's expertise in biophotonics. You can come up with anything. And sometimes our solutions at CBID, you'll see even our global health projects, which are about half of our projects, we have things that are absolutely simple training tools, posters, cloth-made, fabric sewn things to teach people how to put in an IUD, or teach a midwife how to know whether a baby needs C-section or not, or very complex devices, focused ultrasound for ablating the carotid body for blood pressure control. I mean, really sophisticated stuff. We're not here to prove how clever we are. We're here to solve the problem. So we use anything that will solve the problem best. And then the last third of the year is spent building that solution, de-risking it, getting some initial confidence, preparing the groundwork to make a wise decision to pursue or kill the project. And we use the 4 quadrants as filters. We look at, for example, the need that we're solving. Is this a good project to work on? We look at it from all 4 perspectives. Is it big enough in terms of its clinical impact, the problem itself? Does the intuition of the existing practitioners tell us that there has to be a better way to do this? This is just not adequate. The existing solutions are failing us. From a business perspective, is this problem, the existence of this problem, costing the healthcare system significantly, where there's going to be resources and funding available to solve it, because people know society is wasting $1 billion a year on this problem. They're willing to invest, $100 million to solve it. From an engineering perspective, that's why it's good to have an engineer always around someplace. Does your intuition, engineers have an intuition, what's doable with existing science and technology, and what will require the invention of an anti-gravity machine or something totally new? So it's good to have that intuition where people can say, you know what, I think this should be solvable with existing science and technology, before you even think about how to solve it. And from an entrepreneurial perspective, does this align with my interest? Do I have a passion for this? Do I have the right partners in place? Do I have the right experts in place to work on this? And the right money and resources? So you may have many, many possible projects you can work on, and we apply these 4-fold filters and come up with the ones that are the top innovation targets, the top needs. And once you've done that, in the second phase, we do the same thing for all the solutions. We ask ourselves questions for each of the solutions we come up with from each of the 4 quadrants. Does the solution solve the problem medically? Deliver healthcare-wise? Can it be built within those cost constraints that we talked about? From an engineering perspective, does it actually technically work? And from a team perspective, entrepreneurship perspective, do we think we can actually build this and make it a success? And you may have many solutions that you've thought of, and you should filter them with this comprehensive 360 perspective. And pick the ones that make the most sense. And that's what we do in our program. And then the last third of the year, we manage risks. We say, we have a problem, we have a solution we think is going to work. What are ways that this solution could fail? From a medical perspective, from a business perspective, from a technical engineering perspective, and also from an execution perspective, the project itself failing. For example, one of the ways teams fail is that the teams don't get along. They have a squabble over something. Managing that is critical. In industry and in startups, it's one of the big failure modes. The relationships fall apart. The incentives are not lined up. So here's some examples of some outcomes. Spineline is one of them from a few years ago. The two folks at the top are 2 of our students, and they work with a couple of spine surgeons here and came up with a great way to allow surgeons to do a better job of aligning the spine for scoliosis and other things. And it was spun out after 4 years. It was acquired by another company. Here's one that's very simple. So that was a high-tech solution. This one, the problem was the students observed, and they did the analysis. There were billions of dollars wasted every year managing chronic wounds, like bed sores. And the way that nurses track the treatment was using a ruler. They just put a ruler next to the wound, and they guessed the size of the wound. And this had huge implications for reimbursement, who's going to pay. If the wound is getting worse, the government says, you guys screwed up. You should be taking better care of your patients. I'm not paying for the additional care. The wound has to be getting better. But there's a 50% inconsistency between nurses doing this. So the team said, we're going to take our cell phones and we're going to take a picture of the wound and we're going to use that to measure accurately the wound. Except, how do you control for the distance between the cell phone and your wound? The bigger the distance, the smaller it looks. And the angle will change the shape of it. And the illumination will change the appearance of it. How do you correct for that? Anybody have a suggestion on how you could correct for those changes?
A standard.
A standard. Yeah, what would you use as a standard? Excellent, excellent, excellent. 3 points. That's good. My engineering students thought, I'll use LiDAR, laser, radar, high tech. They're electrical engineers. They want to bring in the most sophisticated laser-based approach. It'll cost like $1,000. They had all these different, I'll use 4 or 5 different cameras and triangulate and do all this stuff. And 3D imaging, And then I sent them to the office supply store. I said, go buy a package of 1,000 of these stickers that you put on the folders. Because you buy one package, they're all printed at the same time. So they have the same exact color, the same exact ink. So and every time you take a picture, just stick the sticker nearby. And that can be used to calibrate the illumination, the size, and the angle. And it gets the accuracy down to 5%, less than 5%. So that became a spin-out company called Tissue Analytics, incubated right here at Hopkins through JHTV and the incubator down the street. And they actually were acquired by Net Health a few years after that. So we've done projects in global health in all of these countries. I neglected to add Colombia. That's our latest addition to our list of countries we've been to. In China, for example, we've been in coastal China, but also interior, Kunming and other cities far in the interior of the country, as well as the wealthier coastal areas. In India, throughout the country, from the poorest areas in the Sundarbans in the Bay of Bengal to the most advanced hospitals in Hyderabad. Here's an example of a product the students worked on. So this cryopop is a great project. The team observed women coming to treatment screening clinics for cervical cancer in Kenya. Except one of the complaints they heard was that the equipment used, which is on the top left, the cryoablation tool is constantly getting clogged up. They have to go and get a canister of CO2 that feeds through these tubes and freezes the tip. As the gas goes in, it freezes and expands. So that's used to press against the cervix and freeze the tissue to burn off the precancerous or cancerous lesion. The problem was it was expensive, it was complicated, hard to repair, it required a large amount of CO2. So what the result was, oftentimes the treatment was not available. So a woman would get screened, she would do the acetyl whitening or some sort of screening for cervical cancer or lesions, and she would leave and she wouldn't come back until the cancer was advanced. So the goal was to make it so it would be so cheap and easy to do that it would be see it, treat it, done, one shot. That was the idea, but how to do it. So the team invented this thing called the cryopop. So it was like a little plastic thing there at the bottom. This brown part actually is a hollow tube with a spring-loaded pusher in it. And they take a smaller container of CO2 and turn it upside down so the liquid part goes into this tube, causes a block of dry ice to be formed. And then the spring pushes the dry ice slowly like a push pop. You see popsicles or push pop. Like a push pop, pushes it against the cervix, freezes, evaporates, and has the same cryoablation properties as the expensive device, but it only costs like $10, and there's no tubes, and it uses a lot less CO2. Solve the problem. So it's on the market actually in India, and it's saving lives every day. Here's another one that came out of our program, which is called IntelliHealth, which is a tool for people in rural clinics. Telemedicine has a problem in that the people in the telemedicine, the remote clinics, don't do a good job of capturing the information about the patient situation in order to allow a doctor to make an accurate diagnosis. So the team went to India, did all these observations, and they scoured the textbooks and wrote up a whole bunch of rules on what questions to ask. This is pre-AI. Now LLMs can do this immediately. But at the time, they created this app, and it basically guides So this woman here is a high school student who was trained by IntelliHealth to use the app to ask the right questions in the clinic, gather the right information, and the questions are guided, just like you or I would hear from our doctor when we go to get a checkup. If you say I have a stomach ache, that will guide a certain number of questions. If you say I have a headache, it'll guide a different set of questions. And the app does that, captures that, sends the information in a compressed way to a doctor to get the diagnosis back. And now IntelliHealth has about 10 million patients in India have been seen using this app in their clinics. I invite you to go to their website, intellihealth.org, and hear about it. We also have a lot of projects working with the Arvind Eye Clinic on how to go out to remote clinic areas and use simple technologies like smartphones to do some pre-screening for cataracts, for example. And then if the risk is high, to send them to the Arvind Eye Clinic to get further treatment. And we found that ML, machine learning, to be very effective for that. Here's a list of all the projects we've done in the last 13 years. And the ones in green are the ones that actually have been translated into real work. And you can see there's a wide range of medical topics and a wide range of technologies that are involved. And not all of them go anywhere. I think if we get to a ratio 1 out of 5 that actually shows impact, I'm happy. And the yellow ones are the ones that are licensed by others to develop. So we've done about 130 projects, about 56 global health projects, and they've done quite well over the time. So that's it. I'll stop there. Thank you very much for your attention.
Maybe I'll start just how to partner with CB.
Wonderful. Well, listen, the key is, I think, finding a worthy problem that you think calls out for a creative, innovative solution. That's really that's really the gold mine. And you all are in the trenches in your field. So think of problems where the impact is significant on people's health, where the existing solutions just are totally inadequate or largely inadequate. And you feel like that there must be a better way to do it. And we can work on that together. What we would do is in the spring semester, we tee up new projects for the new cohort, which start in June. So we start the discussion. Now is perfect timing. So we can start the discussion in January, February, tee up what the project is going to be, what would be the target location, where in the world would be the best place to do it, where can we get this thing funded. We have some seed money. Sometimes our partners from medicine or public health have some money to get the project rolling. By the end of 1 year, actually usually halfway through the year, we have enough momentum behind the project, we start applying for grants and we can get it funded.
I see. But then, so the starting point to reach out to you, or
yes, just contact me. No, just have a conversation. Say, hey, I think I have a project that would be a good one for a CBIT design team for their global health project. And this is the problem, and this is why it's such a big problem, and why the existing solutions suck. And this is a country where it should be, where we could go. And these are some potential places to fund it. And then we go from there. And so then we work that out like June, May, by May, we want to have it all locked down. So the new cohort arrives in June and they start preparing.
John?
Yeah, so I think one of the big differences with public health versus medicine, we don't really have a customer. Medicine has a customer. They treat patients, they have a product. We don't really have a product. So I'm just curious, and we don't see patients, we're not on the ground for a lot of these things. A lot of our work relies on a population rather than individuals. So if there's some cases that you see, that would make sense, because also as academics, we don't buy. We don't spend. Not really. Right? We're very cheap.
Perfect. So I'm just curious of things that you see in a school of public health that make money, because we do a lot of things for the public good, things that might align that, because we're not medicine. And so I'm just curious of how you would think about adapting some of these similar processes for a public health question.
Excellent. So the question was, how would you adapt this discussion to fit the world of public health and global health? Excellent question. And we've given some thought to that. In fact, half of our projects are related not to the Western capitalist model of medicine. And the terminology will change. The basic principle is the same. For example, if you're trying to sell an innovation to CMS to pay for it, or to United Healthcare to pay for it, or the Value Analysis Committee, you have to make a case. How every dollar I'm going to spend with your company to buy this is going to save me $2? The same conversation happens at the Ministry of Health, or for the Public Health Department of the state of Maryland. Why should they pay $1 million for solving a problem? You have to convince them that if you solve that problem for $1 million, the state will save $5 million. So the fundamental logic is similar, but the terminology differs greatly, and the payers differ greatly. But I would disagree with you respectfully that you don't have customers and you don't have products. You do. You have, instead, perhaps we can generalize the term to stakeholders.
I would say, I guess my rebuttal would be like, the hospital, they get paid from insurance companies, they treat patients. A lot of the school public health being soft money, we don't make money other than we get grants, which are a very different process.
But why would someone give you a grant? Why would the Gates Foundation give you $1 million?
Generally for a public good most of the time.
Exactly, because they see that the $1 million they give to you is going to result in $10 million, $100 million in worth of savings in the healthcare system, because people are needlessly dying from early, the survival for breast cancer in sub-Saharan Africa is 40%. In the United States is 90%. Those women who are dying needlessly because they're not getting the care they need are costing the economy, costing their families. And costing the Minister of Health. So those are things that, though there are customers out there. You just have to broaden the definition of the term, perhaps.
I like what we were discussing is about like stakeholder, customer. Maybe it's not about how the insurance will pay, but maybe it's to reduce the health burden. But intrinsically, this is linked to the cost.
Yes.
That's what you are trying to say. It's still about saving life, but at the same time, this is a new innovation. Would save a lot of money along the way.
Yes, exactly. Because there's a reason why poor countries are poor, and a lot of it has to do with inadequate healthcare. That they're losing a huge part of their productive workforce to disease needlessly, to malaria, to breast cancer, to other diseases that could be, and if they're addressed, then the society would advance. So there's an economic story behind it as well, behind healthcare, and not just a health story.
Great, thank you. My name is Cassandra McIsh-Gross. I'm the Business Development Director for the Center for Communication Programs, which is part of the School of Public Health. And so I really appreciate the way that you've sort of laid this out and considered the business aspects of your quadrant, in addition to sort of this more engineering and medicine. I think perhaps touching on what my colleague has said over here, the piece that maybe the School of Public Health might feel is a little bit missing from this, maybe it's part of business, but it feels a little bit separate, is sort of that community space. It's thinking about whether we're talking about an innovation as a product or a new approach, whether it's a vaccine or something like that. Like, what is this culturally appropriate within the community? Are they going to receive this welcomely? Like, what is the reaction in a greater context? Like, you have to think about the Ministry of Health as a client, but also community, which I think is true here as well. I mean, anybody's seen all of our opposition to things like that.
Yeah, absolutely. I think,
but I think that's a big part of often how how the School of Public Health would approach things, and just thinking about that, like demand generation and addressing potential challenges with the community is something that would be.
I love that. And I think that could be a good next step for us to work together on. The language here is focused on it was developed for advanced US-based healthcare systems, but perhaps you can modify the language. For example, community health workers in this category. I would probably put the issues raised about alignment with community health workers in this category here. Because in order to deliver care effectively in sub-Saharan Africa, it's different than the way you deliver care here effectively. So those are important factors in that category. And then the payers differ greatly in the US versus in other countries.
I think that's across your quadrants where that can kind of get elevated. But I think that tends to be often our headline in public health, and less like, you know what I mean? It's very front.
That's the thing. Every one of us has a background and a training and a focus and things we think are important. And we focus on that. Like I would love to spend my whole day in the lab with a bunch of soldering iron and a bunch of electronics and lasers and stuff like that. But if I don't pay attention to all these different things in a comprehensive way, my project's not going to really have.
Yeah, I think no matter like what kind of area, like in the community level, we also think about increasing the value, the quality, and the access. And this is independent of the economic situation. And I think that's a part of the engineering solution to help to find that. Yes.
I just want to have a question more about like what CBIT does, because I guess the talk was focused a lot about global health, but at the School of Public Health, there's a lot of verticals that's not necessarily, delivering care in like I guess other countries. Like I guess we develop like therapies, things that crosses more closely with I guess what the School of Medicine does. So is there any other like sort of programs at CBIT or verticals where students work on projects that are global health focused?
So you'll notice our projects are all over the place. So there's not a lot of verticals, but occasionally something will gain some traction and funding, and we'll continue working on it year after year. Like our vector control project using AI for identifying mosquito species for controlling malaria and dengue has just recently been funded a few $1 million by the Gates Foundation to do studies. So that's become a vertical. So we've done that now for 3 years, developing that further. The breast cancer one is something we're working on developing funding for right now. We'll probably make that a major vertical. Another one, we're working with the Intuitive Foundation to develop tools for training midwives and in women's health issues for surgical training tools. So there are a few verticals like that we spend a lot of time on, but sometimes some really cool things come along and the students are passionate about it, or some sponsor or some grant is really going to fund it. Like any academic, one thing I learned when I came to academia is like academics are like puppy dogs. If you put the food bowl over there, they run over there. And if you put it over there, they run over there. So if a foundation comes to me and says, guess what? Your new vertical is obesity in developing countries. Count me in. I'll work on that. As long as I'm allowed to follow a good design process and really focus on problem solving, we'll do that.
Youseph, thanks very much for coming. We very much look forward to partnering with you. I had a question more about the formation of your teams and selection of the solutions. The relatively small teams, and you mentioned diverse, like that team was diverse in terms of where they came from, but how about their differing skill sets? And it relates to the selection of the solutions.
Yes.
It could be a product or a device or a biomarker or an app or a systems approach. And I can imagine that if they're interested in lasers or they're a lab background, they might want to work on a biomarker or they might want to work on an AI app. So how do you put the teams together, and do they then vote on what they want to select to work on?
So great question. So the two very different questions. So how we put the teams together, we do a survey of all the cohort and ask them we tee up 4 projects for the US and 4 global health projects. Okay. And we have those teed up before they start. And then we pitch them and we ask them, which ones do you want to work on? What's your top priority, second, third? And which students would you like to work with? And is there anybody you don't want to work with? And then we do a matching and optimization. So we form the teams in that manner. Once the teams are formed, then we get halfway through the year and they're at this stage where they have 100 solutions. How do we get them to come up with 100 solutions? We have all these tricks for brainstorming. Like, for example, they have a box full of names of different animals. Pick an animal, a stork. Tell me how the anatomy of the stork relates to your problem. Can provide a solution to your problem. Just get them out of their comfort zone to think broadly. We ask them to show us your crazy, stupid ideas, not just your really cool, slick ideas. And then we ask them to think very broadly. And then we start filtering down using this as a filter mechanism. Like, which of these actually do we feel like is going to work? Which one do you think is going to have the biggest impact medically? It's a heated discussion. Right now, like all of our teams right now, it's like end of December, there's a couple of teams that are like arguing between themselves with 2 different solutions. They're down to 2, okay? And then I sit down with them, mentor them. Their clinical experts come in and say, my intuition is project, solution A is more likely to work than solution B. In your case, you have a lot of tremendous expertise and depth in implementing projects around the world. You can say, listen, these are 5 reasons why solution A will not work. Solution B is better. So that's the approach we've taken. But we get it wrong a lot.
I noticed there was some business training, and how about the cultural competency component, particularly of sending people to rural Uganda or high in the mountains in Nepal? Like, what is your preparation? Because not everyone's going to walk in with the cultural competency that's needed to go into those settings.
Excellent. So over the summer, while the students in the summer are doing clinical rotations at Hopkins, and then we also have a series of lectures to prepare them for their global health trip in August. So they spend the entire month of August overseas. And we prepare them through lectures in cultural competency, the lay of the land, the healthcare systems, how things are paid for, what are some of the challenges, et cetera. And then how things are regulated in Uganda and East Africa, et cetera. And then also we have people come in who've been in the field a lot to give them conversations about how to behave, things to say, things not to say, how to watch out for power dynamics in a hospital. Like, we went to a hospital in Gwangju, and it was a cardiology department, and we asked them, like, how do you treat this kind of patient and that kind of patient? And everyone just stared at the chairman every time I asked a question. No one dared speak out first. And we're just waiting for the chairman to comment first, and then they all just nodded their heads. So we had to learn how to deal with that by having individual conversations with people to get their opinions.
My final question builds on those to talk about how to develop this perspective within our school. Because we are looking for the bowl of food as puppies and funding and things like that. And that will encourage many of our faculty to think of this as an alternative path. But just there's a fair number of people who have cross-training in public health and medicine. But at the same time, there's not that many who are dually trained in engineering and medicine. Yet you have formed very highly collaborative teams. But there needs to be that shared language, respect for the other perspectives. Doing it and being involved in those teams is the way you probably acquire those skills. But are there other things we should think about as a school to facilitate this? Is it just learning by practice? Are there, I don't want people to have to go to classes or get certificates, but are there other ways to facilitate this type of thinking? Because we're only going to get a few solutions. We want this to have broader impact at the school in developing this sort of perspective, as opposed to, we certainly would love to get 1 or 2 of yours, but at a broader scale, how do you foment that type of perspective?
So we've been working with institutions around the world and helping them create programs like this. A lot of people see the value in it. The number of programs are expanding, and I think it's a matter of creating a program. It could start out small. We start out with just 3 teams with 9 students, and we gradually built over time. Teaching the principles, having a team, they succeed, they become exemplars for others. People say, oh, that's pretty cool. It attracts different kinds of funding than the traditional grants, because it's all about impact, and the kind of donors that like this, they'd love to hear a story about how we're actually going to solve a real world problem as opposed to advance the frontiers of knowledge on this certain topic. So I'm happy to help in any way. Count me in, to help the school, and I think that could be the basis of our partnership. Yeah. But it does take some effort to like manage through the process. Maybe start with a few teams, 1 or 2 teams, and then go through the process. Another way is to have students come through the program, and the applications are due January 7th if you're interested in doing a master's degree in medical device innovation and medical innovation. And then go back with the promise that they're going to come back and lead a program like that in your school. That would be a good investment. You have a couple of people do that, they go back, and now they're the champions who lead the program here.
Have you hosted like design thinking workshops or?
Yes.
Like we bring a few people in with real ideas about unmet needs and problems that need solutions, and we sort of develop that, whether they go forward with you or not. That would be good for us.
Yeah, we did. During the Ebola crisis, we received a grant from the USAID to do a big hackathon. We did that, we had like 100 people, maybe like 10 teams, And then they came up with all different types of solutions, PPE doffing, PPE cooling, all sorts of fogging, all sorts of different aspects of the problem. During the Zika crisis, we did the same. During the COVID crisis, we did the same, except we did it all on Zoom. So people came in, we did pitches on Zoom, explaining the medical problem, explaining the process, and then we divided everyone up around the world in teams with 130 teams, 1,000 people. And they came up with some ideas, and some of them we helped them through the process, but then beyond that, we gave them a little bit of award money and they ran with it. During the humanitarian refugee crisis, we did hackathons with students in Beirut and Gaza, especially during the Syrian Syrian civil war. There's a lot of refugees in Lebanon, so the teams were focused on healthcare issues in refugee camps, things like gender-based violence in a refugee camp, how to mitigate that concern. And the teams would come up with solutions and came up with some amazing solutions. So that's one of the tools, is these hackathon approaches.
Thank you very much.
You're very welcome. Thank you so much.
Thank you.
Thank you.
Yeah. So for all of you who would like to know more about the innovation translation activity, so we have a lot of representatives in individual departments. You can go look into it. And we also want you to join the next Innovate360 to learn on the digital entrepreneurship. Thank you.
There's some more brochures. I gotta run to the next one.
Yes.
Thank you.
So do you want?
Oh yeah, there's some brochures out in the hallway if you're interested in more about the program.